This is Heliox, where evidence meets empathy. Independent, moderated, timely, deep, gentle, clinical, global, and community conversations about things that matter. Breathe easy, we go deep and lightly surface the big ideas.
Welcome to the Deep Dive. Today we're really getting into something important, a new type of cellular therapy. Our mission, if you will, is to cut through the complex science behind it. It's designed for, well, the most vulnerable COVID-19 patients. We're looking closely at the phase 1 trial data for a therapy called TVGN489.
That's right. And it's crucial because, even with vaccines, some groups are still really struggling. We're talking about older individuals, people with cancer, or serious autoimmune conditions. Their immune systems often don't respond effectively, leading to poorer outcomes. So there's a real need for something different, something targeted.
Exactly. And this deep dive focuses on a phase 1 study. It's all about the safety and, well, the feasibility of using these specific cells called cytotoxic T lymphocytes or CTLs. These are third-party cells taken from donors specific to SARS-CoV-2. The big question is, can we safely give high-risk patients this kind of immediate immune boost?
Right. And what's initially quite striking, even for a phase 1 safety trial, are the signals we're seeing. The safety profile looks remarkably clean, and perhaps more surprisingly, the data points towards really rapid, very consistent viral elimination. So we need to unpack how this off-the-shelf product managed that.
Okay, let's do that. Starting with the basics. CTLs. We hear T cells a lot. But what makes CTLs the right kind of precision fighters for a virus like SARS-CoV-2?
Good question. So CTLs are a specific type, the CD8 plus T lymphocytes. Think of them as the specialized assassins of your adaptive immune system. Their job is totally different from antibodies. Antibodies kind of tag the virus floating around outside cells, but once the virus gets inside a cell, antibodies can't touch it. That's where CTLs come in. They're trained to find those infected cells and destroy them. They basically shut down the virus factory.
Got it. Now, this specific product, TVGN489, is called off-the-shelf. That sounds counterintuitive for T cells, which are usually so personalized. How could it be pre-made or allogeneic?
Yeah, that's really the core innovation here. It is allogeneic. It comes from a healthy donor who already recovered from COVID-19. They've essentially created this potent, ready-to-go defense force. And crucially, these cells aren't genetically modified. That keeps things simpler, potentially safer than, say, CRT cells.
But hold on, if they're donor cells, wouldn't the patient's immune system just attack them immediately, recognize them as foreign? How do they get around that rejection problem?
Right, that's the fundamental challenge. They manage it partly. They don't eliminate the mismatch entirely, but they minimize the issues. First, the CTLs are generated to target 7 very specific bits peptides from the SARS-CoV-2 virus, spike protein, nucleocapsid, other bits too. But here's the key constraint. The therapy is only for patients with a specific genetic marker, the HLA-A02.01 allele.
HLA-A02.01. Okay, that sounds very specific. What is that, and why is matching just that one marker enough?
So HLA stands for human leukocyte antigen. Think of them like unique ID tags on your cells. They tell your immune system, this is me or this is foreign. We all have lots of different HLA types. HLA-AA02.01 just happens to be the most common one across the global population. Choosing that specific one makes an off-the-shelf product viable for a larger group of people.
Ah, okay, so it's like having a master key that fits a very common lock. By matching just that A02.01 lock, the donor cells get enough clearance to go in and hunt the virus, without triggering a massive immediate rejection by the patient's own immune system.
Exactly. It's a calculated risk, a trade-off. It lets the donor CTLs stick around long enough to find and kill virus particles presented on that specific HLA type, and the product itself was potent. The final infusion mix was nearly 70%, 68.5% to be exact, pure SARS-CoV-2 specific CD8 plus CTLs.
Okay, let's shift to the trial itself. Phase 1, 30 high-risk outpatients. How do they structure the study groups?
Right, 30 patients enrolled. But only 12 of them actually had that matching HLA-A02.01 allele. So those 12 became the interventional group. They got a single infusion of the CTLs, with the dose increasing across 4 subgroups. The other 18 patients didn't have the matching allele. They formed the observational group and just received standard care. This gave a useful comparison point for how high-risk patients normally fare.
Right. Now, for the crucial part of any phase 1, especially with cell therapy, safety. Introducing foreign cells always carries risks of serious toxicity. What do they find?
The main finding: Overwhelmingly positive on the safety front. The SARS-CoV-2 specific CTLs were exceptionally well tolerated across all 4 dose levels, and critically, there were 0 instances of the major complications you worry about.
Okay, let's pause there because this sounds significant. You said 0 incidents, no dose-limiting toxicities, no infusion reactions, no cytokine release syndrome, and importantly, no graft versus host disease, GVHD, throughout the whole 6-month follow-up. Can you just remind us why zero GVHD is such a big deal here?
Yes, that really is the headline finding for safety. GVHD is, well, it's when the donal T cells start attacking the patient's healthy tissues, skin, gut, liver. It sees the host as foreign. It can be devastating, even fatal, and it's a major risk with many allogeneic transplants. The fact that they gave these third-party cells, matched only by that one HLA type, and saw 0 GVHD, it suggests their manufacturing and selection process hit a sweet spot. Potent against the virus, but seemingly safe for the host.
So the safety looks more like what you see with simpler virus-specific T cells, VSTs, used after transplants maybe? Not like the complex, sometimes toxic CRT cells that need intense monitoring in hospital.
Precisely. That's a huge potential advantage for an off-the-shelf therapy that could potentially be given on an outpatient basis, much simpler. And they did check for rejection later on something called alloimmunization. Only 1 patient out of the 12 developed antibodies against the donor HLA type. But even in that 1 patient, the donor CTLs still persisted in their blood. So no functional rejection seemed to happen. The cells stayed on the job.
Okay, safety looks good. Let's pivot to what happened when these CTL fighters were actually deployed. Viral clearance. You mentioned this earlier. The rates sounded almost unbelievable for these high-risk patients. How quickly did the virus actually clear out?
The speed and, maybe more importantly, the consistency were really notable. They used nasal swabs and PCR tests. What they found was remarkable clearance quite quickly. 11 out of the 12 treated patients, that's 92%, showed at least 88% viral elimination by just day 4. 4 days after the infusion.
Wow, day 4.
Yeah. And it just got better from there. By day 14, they saw over 99% viral elimination in all the treated patients.
That's a very rapid drop in viral load. Did the patients actually feel better that quickly? Did it translate clinically?
It seems so, yes. And again, the consistency was key. Patients in the interventional group consistently reported definite symptom improvement within just 2 to 3 days after getting the cells. Now, compare that to the observational group, similar high-risk patients, but just getting standard care. Their improvement was all over the place, anywhere from day 1 up to day 23. The median was day 4, and complete symptom resolution. Also faster in the CTL group. Median 8 days compared to 11 days median in the observational group, which had a huge range up to 180 days.
Let's drill down into that high-risk group, specifically the immunocompromised patients. These are the people whose own immune systems often just can't cope. Did this targeted boost work for them?
Yes, and this is where I think the results really highlight the potential impact. Half the treated group 6 out of the 12 were immunocompromised. They were on treatments for cancer or autoimmune diseases, and the source material actually gives a couple of really powerful examples, sort of anecdotes, involving cancer patients.
Oh, tell us about those.
Okay, so there were 2 cancer patients who got the CTL therapy while they had active COVID-19. The therapy apparently cleared the virus so effectively, so quickly, that they were able to proceed to their planned stem cell transplants shortly after. These are procedures that wipe out the immune system, so you cannot have active COVID. One transplant happened just 16 days after the CTL infusion, the other at day 28. Think about that, going from active, high-risk COVID to being clear enough for a major transplant in just a few weeks. And critically, there were no COVID complications, no reactivation of the virus during or after those transplants. That suggests really deep viral eradication.
That's clinically huge. Reducing that delay could be life-saving in itself.
Okay.
Follow-up question, though. Did bringing in these super soldier donor cells stop the patient's own immune system from learning to fight COVID later?
That's a really important point, and they tracked it. The answer seems to be no. The therapy acted like an immediate bridge, clearing the acute infection fast. But it didn't appear to suppress the patient's own natural immune response developing underneath. These patients still developed their own antibodies, their own cellular responses to SARS-CoV-2, so it looks like an additive defense, not something that replaces or blocks the host response.
Right. That leads us to what might be the most surprising, maybe even confusing finding. Durability. These are donor cells, allogeneic. Basic immunology says the patient should eventually reject them, right? But you're saying they stuck around for 6 months. That feels wrong? Is that real? Does it point to something new happening?
It is definitely the most unexpected finding. Yes, donor-derived SARS-CoV-2 specific CTLs were detectable in all the patients they tested, especially at the higher doses, throughout the entire 6-month follow-up. That level of persistence really wasn't predicted, and it suggests something is keeping them active, keeping them stimulated in the patient's body.
What could be stimulating them for that long? The acute infection was cleared weeks, months earlier.
Well, this is where it connects to a really interesting emerging area of research, the idea of persistent viral reservoirs. The theory is that even after you clear the active, replicating virus, fragments, bits of viral protein or RNA can linger in tissues for months, even years. These aren't infectious, but they might be enough to cause chronic immune system weirdness, maybe underlying long COVID or PAS-C. So the thinking is these super persistent CTLs might be sticking around because they're continuously finding and reacting to these low-level viral fragments. They still have a job to do.
So the therapy isn't just hitting the well-known spike protein during the initial infection. It's designed to hunt down other viral parts too, potentially cleaning up that leftover debris.
Exactly right. TVGN 489 was designed to target multiple viral proteins, 7 different peptides from across the viral genome, not just spike. And that's crucial because some research suggests it's often those non-spike fragments that persist and are linked to post-acute COVID sequelae. So having that broader targeting is a potentially huge advantage.
And did this multi-target strategy hold up as the virus kept changing?
Yeah.
We went through Delta, Omicron waves during the study period, right?
It did. According to the report, the specific peptides targeted by these CTLs weren't affected by the mutations seen in the variants circulating during the trial, all the way from Delta through Omicron BA.5. That suggests this approach might be much more variant-proof than, say, monoclonal antibodies that target only one specific, often mutable spot on the spike protein.
Okay, so exceptional safety, rapid clearance, this unexpected durability possibly linked to clearing viral reservoirs and variant resistance. It's not surprising the commercial side is taking notice. You mentioned evaluation.
Yes, the company developing this put out a risk-adjusted net present value estimate. It was in the range of $9 to $11 billion for TVGN 489. That number really reflects the perceived huge unmet need, both for treating acute high-risk COVID effectively, and now, perhaps even more significantly, its potential role in tackling long COVID.
Okay, let's try and wrap this deep dive up. We've explored a phase 1 trial showing, well, really exceptional safety, 0 major toxicities like GVHD. We saw rapid, consistent viral clearance in very vulnerable patients. And then this completely unexpected 6-month persistence of the off-the-shelf donor cells.
Exactly. What these results really suggest, I think, is that these third-party CTLs could be a safe, direct way to rapidly boost someone's cellular immunity right when they need it most. They seem to fill the gap when the patient's own system is struggling. They provide a powerful, fast, and surprisingly durable response that might fully eradicate the virus, addressing both the acute illness and maybe the roots of those chronic symptoms, too.
Which brings us to a really interesting thought for you, the listener, to take away from this. We saw a single dose of these allogeneic third-party CTLs persist for 6 months, likely kept active by some kind of persistent viral reservoir. Now, this kind of durable, targeted off-the-shelf cell therapy can safely hunt down and eliminate chronic infectious reservoirs. What could that mean beyond COVID? Could similar persistent targeted cells be engineered one day to track down and eliminate other kinds of chronic disease reservoirs? Maybe low-level cancer cells, or the triggers for autoimmune flare-ups. Something to definitely mull over. Thanks for listening today. 4 recurring narratives underlie every episode: boundary dissolution, adaptive complexity, embodied knowledge, and quantum-like uncertainty. These aren't just philosophical musings, but frameworks for understanding our modern world. We hope you continue exploring our other podcasts, responding to the content, and checking out our related articles at helioxpodcast.substack.com.